Okay, so this final lecture for ethics will be going over standards on therapy. Now we're going to talk about informed consent to therapy. That's standard 10.01A. And this is talking about when we obtain a consent for therapy with our clients, that we have to make sure it's feasible within that therapeutic relationship in terms of the nature and anticipation. And that's including giving basically the ground rules of everything that you plan on doing with the client at the very start. You'll be discussing what fees might be available, if there's going to be involvement in any type of third parties, that being their medical, if you have to contact and work with their medical staff, if there's social work involved, multidisciplinary basically. You also have to make sure at this time to discuss limits of confidentiality and also give them an opportunity to be able to ask questions as well as receive questions. The main thing here, what I like to do as far as when I'm treating and working with clients, is allow them to share what their expectations are in terms of when they're getting psychotherapy. This can give you the opportunity not only to find out uh, exactly their understanding of what therapy involves, but to also any type of misconceptions they may have about it, to be able to clear the air at the very beginning. You want to be able to demonstrate and provide ground rules, and that is actually all about the informed consent to therapy, making sure we're providing all the information that is necessary for us to be successful in developing and establishing rapport and that therapeutic relationship with our client. And as you can notice that in terms of other standards that will be involved with this particular standard, you would want to make sure you're reviewing 4.02, discussing the limits of confidentiality. And of course, that's talking about in the event that they're attempting to harm themselves or someone else, if they're suicidal or homicidal type of behaviors, you want to be able to express to them that during those times that you are bound not only by the ethics code but by law to have to make a report on such. In terms of fees and financial arrangements, you also want to be aware of that, because there are different instances in which you would you can't deny a client for treatment simply because they haven't made a payment. You can follow every suit possible to get payment, but you can't just cut them off per se. So make sure you do go over fees and financials arrangements so you can have a clear understanding on how that works. As early as feasible, that's 10.01, and they use this feasible because there are going to be times when you're not able to get the informed consent at the very start. So you want to try to do this as soon as feasible. Most times that's going to be during an emergency situation. You may not be seeking out consent at that point. You're seeking to make that client safe at all costs. Therefore, the traditional form of going through the rules and regulations, fees, and so forth goes kind of out the window, because you're now working on an emergency basis. So you want to be sure that when the client is stable enough, that you go through that consent at that point. Okay? When we're talking about the nature of the therapy, here we're talking about information that's part of the therapeutic process. Like I mentioned before, you want to be able to provide the client with exactly how would therapy go. If you're a cognitive behavioral therapist, for example, you'll discuss the fact that there's going to be an anticipation of homework assignments that you would be working toward being directive. You would want to explain the type of therapy you'll be providing. Okay, so informed consent should include information such as the duration of each session. You want to let them know if it's going to be 50 minutes, and you want to also start throwing in about the boundaries of such that, it's for their benefit that we structure therapy in a way that's going to be productive for them, meaning that you're not going to go over 50 minutes, unless it's reasonably have to. If there's an emergency situation, you may find yourself going over that 50-minute mark. But overall, you're going to explain that process to them and letting them know about time constraints. You'll talk about appointment schedules and the fact that, if they're, late, if you have a certain time limit, you may want to make sure, again, because of boundaries, ex- let them know the expectation that if they don't maintain their appointments, what can happen. Some practices will actually charge them for that session if they miss it, if they don't contact the clinic in a appropriate time span. So those are the type of things that you might explain. And again, just objectives of what treatment's going to be like for them. Now, that anticipated course of therapy, I know it's starting to sound redundant, but it's important that we break it down in such a manner. Is talking about how many sessions you expect for this to take before the client should show adequate progress, and also in explaining that they may and they may not, because it's all on an individual basis. But you're going to use this given your current understanding about the presenting it problem, your expertise and competence within the area, the place that you work. If you're working within a hospital, you might have to do brief therapy. So all of these things will take into account. Also, consideration has to be the health plan policies that might affect them. If you're doing it for, particularly like for the EOE, you may only have 3 sessions to work with them. So that's all type of things that you have to let them know on what to anticipate during the course of therapy. When we break down fees further, you want to at least let them know what the cost of therapy might be, how reimbursement would be expected, that being they might be able to utilize if they have insurance, their co-payments, whatever that might entail, if they can use credit cards or checks or cash. These are the type of things that, yes, we as psychologists would explain to them. The payment schedule, if that means that they have to pay before they're seen for that day, that's the type of things that you would talk about. And as well as there's times like right now we're in a pandemic, and a lot of people have lost their jobs. A lot of different places may offer waivers, they may offer discounts, and these are the type of things that you would also bring up. Again, you want to go over what late payments and missed appointments, those policies are based upon the institution or practice that you're working at. All right, so when we're talking about involvement of third parties, not only are we talking about how we might have to interact with uh, people that's on the client or patient side of venues like their medical staff or so forth, but we might have to also discuss the fact that if they are being forced to do therapy, like it's being enforced through court systems or so forth, that they're ordered for mental health treatment, then we have to also let them know based upon law that some of the information that is being will be divulged based upon that. And most times you're going to divulge progress. You're not going to do word for word. Okay? A lot of people think they have to do word for word. No, your notes should be demonstrating, particularly if it's court ordered, the progress a person's making, whether they are attending. Are they showing progress? Yes or no? You don't have to give explicit information there. But you do need to be able to let them know that even if they're paying for it, that this type of information may have to be released. And that's one of those limitations to confidentiality that you would have to discuss as well. So moving forward, one of the sayings that I usually would say in terms of my clients that for the most part, what's said here stays here. Like that term they use, what happens in Vegas stays in Vegas. I kind of give them that leeway, and then I expressed to them, for the most part, there are limitations to confidentiality that I may have to. There may be times I have to break confidentiality, and then you would explain what those things would be. And of course, in terms of HIPAA, it's you. And if you're not aware of the HIPAA regulations, I suggest and highly recommend that you go through all of it. And I mean, it's intensive, and it's been building for the last 10 years. So you want to make sure that you understand HIPAA well. But our first and foremost is to try to protect all identifying information uh, in terms of HIPAA regulations about your client. No, you really shouldn't be. And I always get my doctor's office. They hate me when I come there because they'll have their sheets out where they want you to sign in, and I put my initials, and then they're like, "Well, we're not going to remember that." Well, you need a new concept because understand you are breaking HIPAA rules by having me write my name down, and then it sits there for several hours while other patients are coming in, signing their name, and they get to see my name there. And thankfully, they've made a change. They went totally electronic. So now when you sign in, it's like you have to put your own information in, and then you clear it when it's complete. So it was like, I guess they got enough of threats from hearing about HIPAA violations from myself, and I'm quite sure others, that they finally made that change. But we have to understand those implications and make sure that we are following all regulations of HIPAA in regards to protecting our clients' rights. Now, informed consent involving children and adolescent patients or clients. When we're working with children and adolescents, we have to constantly make sure we're balancing our ethical obligations to be able to protect our clients' and patients' welfare as respect to the client's patient's development of autonomy and privacy. Now, what does that mean? Now, of course, if they're a minor, we have to get consent for therapy from the caregiver or parent, or legal guardian. However, you should also be getting assent, ASSENT, from the client or patient. You need to make sure that they're willing to do this as well. In that, you also explain to them, because they're a minor, that there is going to be some information that would be shared with their parents or their legal guardians in order to let them know that you're making progress or not. Does that mean you're going to give a word, play-by-play of everything that happened in the therapy session? No, but you're going to be able to have to report on things that was essential that will help, because there's going to be times you're going to need the involvement of the caregiver or the parents anyway in terms of ensuring that therapy is being successful. But like working with adolescents, one of the most difficult things that you'll have is having a teenager trust you, because they just know you're going to say word for word what happens. So you should, in the very beginning, once you meet with the parents or caregivers or legal guardians who is coming in, and you provide the information in terms of getting consent, you should also ask them to leave and have just the child there so that you can go back over it. Allow that client to ask questions, that teenager, that child, to be able to understand that it's with you and them, and that for the most part, again, you're trying to build trust, so you're allowing them to understand that although I need to let them know, your parents know how you're doing, that doesn't mean I'm going to tell them if you say something really negative about them. You would want to also explain, though, to the minor that in times if you feel that their life is in danger, or if the life of others is in danger, that you will have to go beyond, and that's the time you may have to break confidentiality or their privacy. So it's important to get assent from your minor, as well as getting the parents' consent. Now here again, this is giving you a breakdown in terms of that guardian consent. And it's saying, particularly with standard 3.10b, that persons who are legally ineligible to provide informed consent, then we as psychologists should obtain the guardian's permission and client's patient's assent. So that kind of just reflected back on what I was saying. Exceptions to this requirement for child assent would come up when the child is too young or impaired at the point where they're not able to. So, for example, you might be working with a 2-year-old. Even though you're not working toward getting assent from a 2-year-old, I would still let them know, would you like to, would it be okay? I still present it in that sense. They may not be able to give me a true yes, but I'm still working toward helping them be more involved. So you have to know how to work with the client that's in front of you. You do have to judge it based on the age factor. If a 6-year-old is what, and I've worked with a 6-year-old who I always would say to myself, he's far more advanced than any 6-year-old I have met, because with that 6-year-old, I definitely asked, would it be okay if we talk? And he would say, are you telling my parents everything I say? And it was like, well, it depends. I will say this. I'm going to share with your parents if you're doing good or not. Am I going to tell your parents that you said something bad? That you said something naughty? Because this particular client, he used profanity profusely. But he was smart enough to know when I asked, is it okay, whether or not he wanted to say yes or no. So again, it's based upon how you assess your client. But you want to also make sure that you are doing everything in your power to ensure that you are looking out for their well-being. Now, there's going to be times when the guardian's consent is not going to be permitted or be required. And here, these are times when, like I worked in Alaska, we had the advocacy program, child advocacy, in which children who were being sexually abused or considered to be perpetrators, and they were ordered by court. These are those times that even though the parent is going to be present and involved, the parent has no say on whether or not this child has to be seen. The court system is forcing them to bring that child in. So you have to be familiar with the state and federal laws in terms of this, in treating minor children when you don't have the guardian's permission. Because there's sometimes they might be with Department of Human Services. The guardian then is the state, okay? So you have, even though the parent might be still in the child's lives, you might not necessarily have to have their permission. But I still work with the assent quota, letting them know the process as much as I'm allowed to. So again, you want to make yourself aware of the state and federal laws involved, and keep yourself reviewing in that areas. All right. So again, when we're talking about not having to have a guardian's permission, emancipated minors, mature minors, or minors for whom the evidence is that the guardian's decision might not be in their best interest. Who are those? Those might be individuals in which there's a question about abuse or so forth. So those might be particular times. All right, so standard 10.01b, this is talking about when we're obtaining informed consent for treatment which is generally recognized, techniques and procedures that have not been established, then we as psychologists need to inform our clients or patients about developing the nature of the treatment, what would be the potential risk, what alternative treatments might be available at that point, and then the importance of the voluntary nature of their participating. So when do you think that might come into play? What if you're doing research? This was one of those times you might be considering that as well. So also make sure you're refreshing yourself in the terms of boundaries of competence as well as the informed consent. So as we continue speaking about informed consent to therapy, we also have to look at telehealth as well as telepsychology. And I'm going to be sounding really pragmatic in the sense that I'm going to regurgitate information as I read this word for word, because it's really important for you to have a clear understanding. So, of course, with the slide, it's saying with telepsychology, it's electronically mediated therapies that's yet to emerge as established treatments in many contexts in which they're conducted, and that psychologists provide web-based services and should carefully consider the extent to which their services are considered established within the profession, and their informed consent procedures need to comply with the standard 10.01b. So APA guidelines for the practice of telepsychology, and this is coming from the textbook, urges that psychologists provides therapy through telecommunication services to monitor and assess regularly the progress of clients' patients to determine whether the provision of telepsychology services continue to be appropriate as well as beneficial. And when psychologists become aware of a significant negative change in the therapeutic interaction or the client-patient's functioning, that they should take steps to adjust the treatment plan and reassess appropriateness of delivering services through remote services. When it becomes reasonably clear that continuing to provide telepsychology services is no longer beneficial or presents a risk to the client-patient's emotional or physical well-being, then the guidelines would encourage psychologists to discuss these concerns with the client and patient and appropriately terminate remote services with adequate notice, care, and care for the client patient's well-being, and referral to any needed alternative services. So we're looking at how a psychotherapy patient can be changed to health plan that later realized uh, that they wasn't going to be reimbursed with their current psychologist services. And it goes on to talk about how the client told the psychologist that she would not be able to come anymore to any more sessions because she couldn't afford to pay the therapy out of pocket. Thus, would be continuing services with a provider that's covered by her new health plan. And in that case, then the psychologist would discuss the patient's concerns about leaving therapy, and then the patient would appear to be ready to terminate the relationship. So you want to be able to ensure that if such changes are in effect, that it's going to be beneficial for the client, that the transition will be without any detriment. Now, what I also wanted to go over was some updated information in terms of the pandemic. Give me one moment. So they provided additional guidelines that we should be following as a psychologists. And they're saying that we should be able to know that during a crisis, the psychologists may provide telehealth services from home, and that telehealth services can now be provided to both new as well as established Medicare patients. Now, the Medicare patients are no longer required to be in an originating site, and it can be now receive telehealth services in their own homes as well as in any healthcare facility. So prior to that, it wasn't allowed to be such. It would be where, for example, when I was working in behavioral health in Alaska, I did telehealth services all the time. However, it was where the client had to come into one of our remote clinics, and I was able to work from my office inside my clinic. So it was still within a facility, so to speak. But because of the pandemic and issues that arise from it, of course, we're advocating for stay at home. Then that now has been alleviated, even for those who are in receipt of Medicare. So it goes on to talk about how telehealth is available to Medicare beneficiaries in parts of all the country, not just in rural areas. Psychological and neuropsychological testing, group psychotherapy, developmental screening, as well as adaptive behavior assessment and treatment can be billed when providing services through telehealth. For traditional telehealth, telephones may be used only with audio and video functions that provide two-way real-time interactive communication. And as of April 30th, the following recommendations came from APA as well as CMS, which is Medicaid, Commission of Medicaid Services, that announced that many telephones-only psychological services will be reimbursed. So this would be also where they are allowing for patients that are in nursing homes that it could be conducted via telehealth, that any type of inpatient or skilled nursing facility residence can be provided as needed instead of only every 30 days. The telehealth services are reimbursed for the same dollar amounts as well as in-person visits. And providers may reduce or waive cost sharing for telehealth visits during this emergency period. And it doesn't apply to brief communication e-visits that's been described by CMS. So basically, all in all, I'm not going to keep reading. This is information that you can find easily within the APA website and under telepsychology. Additionally speaking, there is a video that I put up for a webinar that's talking about ethical and legality issues in terms of telehealth and what we need to look at and avoid. So make sure, if you haven't watched it already, because I think I asked you to look at that at the beginning of the semester, go ahead and refresh your memory, because unfortunately we are still dealing with the pandemic, and as such we still need to be able to follow ethical guidelines and follow the policies and procedures that's been put into place. Alright, so 10.01 is looking at consent to therapy in the sense of the ongoing nature of consent. If after several sessions a client treatment needs call for a shift to any type of innovative techniques that has not been widely accepted or used by practitioners in the field, then psychologists need to be able to follow the requirements of 10.01b. And again, this is involving ensuring that any type of shift or change that is not a detriment to the client's best interest. If it's where you've discovered that the services you're providing is no longer adequate, this is something you will discuss with your client. You will work toward providing alternative services and making the appropriate referrals. 10.01c is when the therapist is a trainee and the legal responsibility for the treatment provided resides with the supervisor. That the client patient, as part of the informed consent procedure, is informed that the therapist is in training as well as being supervised and is given the name of the supervisor. This starts at the very beginning. You would explain yourself as being a trainee, and you would allow them to know about your supervisor. You would allow them to know that information from the sessions will be discussed with the supervisor, and you can do it in a way to ensure your client that it is in the best interest that they're receiving the best possible services. Not just, throw out there and say, okay, well, I have a supervisor and Dr. Smith is going to be, also involved in the case. You want to give it to them in a way that they understand, that it's clear, but that it's not cold-hearted, if you know what I mean. You want to be able to express, and it helps to establish rapport that, these are part of those limitations that you would be speaking of confidentiality. However, that the supervisor is not for them, but it's for you to ensure that you're providing them with the best services possible during your training period. Now, when we're talking about therapy with couples or families, 10.02a talks about how when psychologists agree to provide services to several persons who have a relationship, like spouses, significant others, parents or children, that we take reasonable steps to be able to clarify the outset which of the individuals or clients or patients. So in this first part, we're talking about that we're going to express how we're working not with just one person per se, if we are doing family or couples therapy, is that everyone will be involved, and in attempts of protecting confidentiality, so to speak, it's of a whole, not of a parts. So you will be meeting with them not individually, but in a group environment, and so that they have that clear understanding. If it's weird that you discover, for example, that maybe you're working with a married couple, you find that maybe one of the spouses really need to have individual therapy. This might be discussed during couples therapy, you know, but not in the context of giving out specific informations on why you might be able to offer those services, in which you can refer them to someone else. It's really not a good idea to do individual therapy with one spouse as you're doing couples therapy with both, because it can get muddled. Information that's being provided during couples therapy can actually drift into the individual therapy, in which now confidentiality becomes a big concern because there's a conflict of interest there. So you want to be careful with that. The second thing is that you also want to make sure to explain the relationship that you will have with each person, as mentioned. And that clarification is to be able to discuss your role within the therapy and the type of services that you're going to be providing, or giving as far as information. And again, of course, you want to discuss those limits that of confidentiality, because even when you're working with a family, if you find one family member might become suicidal, guess what? You have to still deal with that crisis, and you need to explain to them that that can be impeding on limiting confidentiality. You might not go into discussing everybody's situation, but you might have to break it for that one particular person within the unit. So with 10.02, we're also looking at how we have to clarify our roles and goals. We're going to have to talk about our responsibility as psychologists to make sure there are, that we're balancing the interests and making sure that there's no real conflict of those interests between each member. And we have to look at whether or not the psychologists are going to be able to conduct individual or conjoint sessions. And as I mentioned to you just a couple of slides ago, if you can avoid it, at all means, try to, because there will be a conflict of interest. However, if we think about rural areas, or we think about places in which there are no other psychologists, then it's going to be up to you to be able to maintain that professional relationship. And if it has to become individualized as you're working with, say, that couple, then you're going to have to make sure that you do give ground rules that will be strictly informing that client that the work that you're doing individually will have really nothing to do so much with the couples therapy, and that you'll be focusing on the presenting problems for that individual, not necessarily of the couple. And that, like I said, can be quite difficult for a person to be able to follow that. But you're going to want to lay those ground rules down if you have to do it. Again, I would highly recommend trying to avoid that if at all possible, because conflict of interest can creep up quite easily. You'll also explain to them the amount of sessions that you'll have with each party, if you're working with one individually as a couple, and still go through the basics of what the expectations will be for sessions. So in terms of families and therapy, again with confidentiality, we're going to have to take every reasonable step possible to be able to maintain this information confidentially. However, you'll explain the limitations of such. If it's where it's conjoint, or if it's where you have to individualize with one of the couple or family members, then you're going to need to make sure you explain, again, like I mentioned, how it has to be in terms of working with one in comparison to working with that couple. Standard 10.02b will continue in saying that if it becomes apparent that we as psychologists may be called in to perform any type of conflicting roles, like I mentioned, then we have to make sure we're taking those reasonable steps again to clarify as well as modify, or you might have to withdraw yourself depending on those roles, because this can also turn into an issue of multiple relationships, that conflict that I spoke of. It goes on to just speak about how when we're looking at multiple relationships, that there are going to be times when you might be asked to represent one or the other in a dual capacity, and that's usually like in terms of when we're talking about court cases, custody situations. So you have to be careful in that realm. In these type of situations, we have to take reasonable steps to be able to modify or even withdraw from a role that's going to be where we ensure services will continue to be effective and that we're not exploiting or harming our clients. Now, when 10.03 is talking about how we would have to provide services to several people within a group, and even with this, again, at the very start, I could just say it, anytime you provide psychotherapy, at the start, you need to lay out the ground rules. You have to express what is anticipated for the sessions, how long the sessions will be, what the fees will be. You're going to do everything that you would do in an individual case, but it's now in a group setting. And you'll be able to make sure to describe what your role is going to be in terms of being the facilitator, as well as finding out their expectations of what they think group therapy will be like. And you again will discuss what the limit of confidentiality would be. So here's a list again of what's expected at the onset of group therapy. And here you're going to be discussing those differences that's going to be between what's exclusive to your attention as far as an individual therapy and what's going to be really maintained in terms of group dynamics for when you're dealing with multiple people. And the group members' responsibilities, you're going to want to make sure you lay those ground rules out as well, because it can just go all over the place if you're not too excuse me, too careful. So you're going to want to be able to make sure to talk about how we'll take turns, the respect factor, how we got to respect one another. You're going to want to try to stop any type of socializing outside of the sessions, but you're not going to have full control of that, but you should still be able to state this. The reason why is because you don't want the group members to be exploiting or manipulating one another because of information that they have. Now again, like I mentioned, sometimes you can't control that, but it still should be mentioned within the sessions. Policies regarding client and patient's responsibility, you're going to want to talk about language, that there's no profanity if not allowed. You need to express that in the beginning. One thing I always remember when I was doing groups at Mississippi State Hospital, one of the ground rules had to be when I was working with a substance abuse group was that they couldn't glorify their past indiscretions, so to speak. A lot of times you'll find people kind of glorifying their get high days and when the things that they would do. You want to make sure that when we're talking about those diverse opinions, that glorification is not a part of the scenario. It's particularly with substance abuse. That was one thing I always had to constantly work on, because those who were convicted of past crimes, had served time in prison, for example, sometimes they would glorify the experience And if that's not something that you want everybody to think, oh, this is a great thing, then you want to help to curtail that. So pretty much guiding your group to ensure that what you're working on is not confounded with dealing with glorifications. Decisions of group members of a therapy group to be able to disclose confidential information are neither bound by professional codes or are subject to legal liability. But you still want to try to make sure that your group understands that what we're saying here should stay here, that they shouldn't be talking about other group members outside of the therapy session, because depending on where that information can leak out, it could be detrimental to the other group members, and it can also kind of make difficult your group facilitation quite difficult, in that if a person don't feel trust because they think their group members are going to speak out, they're really not going to speak themselves during group. Psychologists have to take reasonable steps to be able to clarify that they can request, but it's not going to be guaranteed that group members will maintain that confidentiality. So you can express that this is something that is expected, but you also should be letting them know within the group that you cannot control each person outside of the group session itself, out of that environment, but that they should aspire and move toward being able to maintain confidentiality throughout themselves. You kind of put it in a way of think about yourself if you would want anybody else to be spreading anything about you, and given those kind of scenarios to be able to help them understand. All right, so now we talk about 10.03 in terms of clients, patients, and concurrent single and group therapy. Here we see how the clients can concurrently be within an individual therapy sessions as well as a group. And oftentimes you're going to find that you'll have clients that you find will really do well, not only with individual but with group therapy as well. And although something, and like I mentioned, there's going to be times you have to be the one who does this. You want to, if there's another group you can send them to, by all means, then there's another facilitator. You would try to send them to that other facilitator. But in places like inpatient facilities, a lot of times you're it, and so you have to ensure that uh, the person is not revealing information for the individual therapy within the group sessions. You'll have to explain and make sure that, okay, I think that group therapy would be great for this particular issue. So that's the one thing you should concentrate on, and try not to bring in the information that we discuss in group therapy, I mean individual therapy. And likewise, let them know that as the psychologist, you will not be talking about their individual situations that you discuss in an individual session, and that you're going to be a facilitator within the group dealing with the group issues and not the individual issues per se. So when you can clarify that advanced type of differences and make sure that there's goals being projected toward those two different entities. That being, you're going to want to have the goals set for individual therapy, and then there's going to be a different set of goals that's going to be for the group therapy. You want to make sure that the client, you know, your relationship with the client, that there's that clear difference made, so that they have that good understanding about the two. So 10.04 is talking about whether or not we should be offering services to anyone that's already receiving mental health services somewhere else. We really have to think about what the situation is for that client, and whether it would be detrimental to them. So if the client is receiving group therapy from somewhere else, then they're coming to you for individual therapy. It's not taboo to say, yes, I can work with you, as long as they understand what you're working with them on are going to be things that's based upon their individual needs and not what they were receiving for a group, because they're probably going to be still in a group. And you're gonna need to express that you really wouldn't want them to be, you would want them to demonstrate confidentiality about their group members and not discuss what happens in group. Okay? Psychologists should discuss these issues with the patient and or client and make sure that the other legally authorized individual on the behalf of the client is understanding and let them know about the minimal risk in terms of how it can be confusing and conflictual. So again, I know it sounds quite repetitive, but it's to prove the point that we have to make sure that ground rules in terms of issues of boundaries and so forth, and ensuring that confidentiality, all these different parts have to be really explained well in order to make sure that we are thinking about the best interest of the client. 10.05, we do not engage in sexual intimacies with current therapy patients. Period. Current, though, is what I have to talk about here. Now, based upon the guidelines, if by all chance, say you develop feelings for a client that you treated 4 years ago, then based upon the ethics code, if you can show that your involvement with them will not be any detriment to them, then that type of intimacy can occur. Now, I said 4 years ago, but the minimum amount of years would be 2, not 4. And what you have to understand here, though, is that you really got to show it and prove it beyond a shadow of a doubt that your relationship with that prior client will not be harmful to that client. And guess what? That's quite difficult to do. So by all means, when we talk about multiple relationships and we talk about sexual intimacies, even though it says current, best advice is not at all, because it's quite difficult to prove otherwise. It goes on to talk about any sexual intimacy between the psychologist and the client and the patient can represent a violation of this standard, regardless of whether the client or patient initiated that sexual contact or voluntarily or involuntarily responds to therapist overtures. Non-sexual physical contact with clients, like handshakes or non-erotic hugging, would not be considered a violation of this standard. There's always been, I can recall when I was going to grad school, and this has been almost 20 years ago now, in which we were taught you don't touch your client, you don't touch your patient at all. You do not touch was the thing. No hand touching, no hugs, do not touch. It was just considered taboo, and rather than uh, make things difficult, that's how they taught the course, expressing no touching at all. But the realization is we're not robots, we're human. And human touch has been proven through research to be able to help an individual during times of stressful situations. Now, what we have to be careful of is how we touch. So I expressed that it's okay to do touching, long as it's not for your benefit, but it's for the benefit of your client. That's number one. Number two, that it's non-erotic and that it's in a way of demonstrating and showing empathy, compassion, genuineness. If you're doing it for those reasons and you're doing it that's not showing any type of sexual overtures, then by all means, you should be allowed to do that. Now, you're going to have some individuals who still feel that's taboo, in which you don't show any type of intimacy in that sense. But As I mentioned, non-sexual physical contact with clients and patients, like handshakes or non-erotic hugging, it's not a violation. So when you hug a person, there's ways of hugging an individual that shows that you care, but allows you to still be careful that no mixed messages can be provided. One of the type of hugs I call is the side hug, not hug front facing each other, but from the side. That would be an appropriate type of way because there's no real intimacy in that. And you need to make sure you time yourself. You don't want to be hugging for 10, 15 minutes because that can be misconstrued. But just a brief hug won't hurt. It actually helps in terms of allowing a person to realize that you're listening, that you're understanding, and that they're not alone in the situation. It's just on how you do it. Now 10.06 is looking at how we should not engage in sexual intimacies with the individual that we know to be close relatives, guardians, significant others of current clients and patients. Psychologists do not terminate therapy so that they can do this either. So the main thing is, you're seeing a client, you find yourself physically attracted to the client's daughter, or to the son, or to another family member, or even a best friend. I'm going to say that because I put that under significant others, because they have a close relationship with your client. We need to avoid that at all costs as well. Ten point zero seven is talking about how we should not accept therapy in clients with clients or patient persons that have had sexual intimacies. It's talking about any of your previous relationships, ex-girlfriend, ex-boyfriend, ex-spouse. You need to avoid them as well. Once there's been a break, you really don't want to be able to come back and say, okay, even though we're not together, I'll be happy to do therapy with you. You need to be careful about that with your former partners. 10.08a is looking at how we shouldn't engage in any kind of sexual intimacy with former, and here is where I mentioned this earlier, it states 2 years after cessation or termination of therapy. But like I mentioned to you before, if you can prove with beyond a shadow of a doubt, then after that 2-year mark, that they're saying that it can be feasible, but it's not encouraged. Now, talking more about that 2-year moratorium, the standard 2-year moratorium period is a moratorium period rather than a permanent prohibition against sex with former clients and patients, because most complaints involving sexual intimacies with former clients and patients actually pertain to the relationship that began during the first year following the end of therapy. And those complaints have shown that relationships that began 2 years post are generally going to be infrequent. So that's where they get the 2-year mark from. Such behavior is not unconditionally acceptable after 2 years. But again, if you can avoid it, avoid it. Part B of 10.08 is looking at how psychologists do not engage with sexual intimacies with former clients even after the 2-year interval, like I was mentioning, for the most unusual circumstances. Psychologists who engage in such activity after the 2-year following a cessation or termination of therapy and of having no sexual contact with the former client patient bears the burden of demonstrating that there has been no exploitation in light of all relevant factors. This would include about the amount of time that's passed since therapy. You would have to show that the amount of the nature and the duration of and intensity of the therapy. So if this therapy, for example, was in regards to anything sexual in nature for that client, guess what? Then you're not going to be able to prove beyond a shadow of a doubt that this won't be exploitative or manipulative of that client. So you're going to have to be able to prove that nature, the duration of it, and as well as the intensity of therapy. Circumstances of the termination, you want to be able to prove that termination occurred because the client made progress, the client no longer needed to be interacting with a therapist at that particular time. uh, it's also involved in looking at the client's personal history. You're going to be looking at their mental status. You have to demonstrate all of these different things, as well as likelihood of the adverse impact on the client and patient of your relationship with them at that point. You'll also have to, it'll be the burden of proof on you to look at any type of statements or actions that's made by you during the course of therapy that would suggest or invite the possibility of post-termination sexual or romantic relationships with that client. So, that's just saying that you need to be able to prove that at no time whatsoever during the time you provided therapy did any type of I say transference and counter transference occurred, that no type of physical attractions was discussed or presented. If it did at all, then you will not be able to prove beyond a shadow of a doubt, even if it was 5 years later, that this relationship started because of the therapy itself. Interruption of therapy, that's 10.09. When we enter into employment or contractual relationships, then we as psychologists, we have to make every effort possible to provide orderly as well as appropriate resolution in terms of the responsibility of client-patient care in the event that our employment or contractual relationship ends. So, for example, if you are let go, or say you're resigning because you're taking a new job, that doesn't mean that you could just get up and leave without ensuring that your clients are going to continue to receive the services that's all due possible. Now, what about if you get fired? How does that work? Well, unfortunately, I do have had that experience as well, and I told you about what caused me to get terminated from a position when I didn't write that report. But when I was let go, I actually had to call back. I called back and talked to my supervisor, in which I expressed everything that all my clients were doing, made sure that they had the notes that I had left behind, and to ensure that they were going to continue receiving the services, even though this was in a facility, continue on the same path that I was on with those clients. For my more troubled clients, I actually wrote them a note that I don't know if they received it, but to explain because they had issues with abandonment. So I didn't want them to feel that I abandoned them, that it wasn't their fault, but it was actually on the fault of us in the administration. So I did leave a note for a couple of my clients that I felt would actually have a setback because of my leaving. Those are the type of things you're going to have to make sure of, because that's interruption of therapy. You want to ensure that they're going to continue to receive the services they are. You got to make sure that, if all possible, that they don't feel it's at their fault. The unfortunate thing about when you're terminated, though, it's hard to be able to ensure that the things that you put in place will be acted upon. I can only hope that those people receive the letters. Uh, because my supervisor wasn't the person terminating me per se, I kind of felt that that supervisor was going to at least ensure that the sense of abandonment wasn't escalated for that client or clients. Continuing on, psychologists can comply with the standard by determining through pre-employment discussions whether or not an organization, group practice, or that entity in which the arrangement can be considered part of the policy that will be designed to be able to ensure that continuity of care uh, when a practitioner can no longer provide services. So another example I can give you that would help is when you first start working in the clinic. These are things that you should be talking about at the very onset of your start at the clinic. How does that process go? What are the policies? I can say and share with you when you go out to externship that if you are still working with any clients within the clinic itself, then that's something in which you shouldn't really be just leaving them because you're now going on externship. You should be at least one good recommendation I would recommend is if you're going to bring in a new therapist, you would have them come and ask them if it's okay to invite them in, allow the client to get to meet them while you're still there, allow them to go over their rules and regulations because it could be somewhat different, but to provide the client a good transition in that interruption. And this is allowing for that continuity of care. Now, when we're starting termination processes, here is talking about how we should terminate therapy when it becomes reasonably clear that the client no longer needs services and that it's going to help them rather than hinder them, and that it will not do any harm by ending such services. So you want to be able to, one thing I think a lot of early therapists make the mistake of is thinking that one session is enough for a termination. It generally isn't, but it also depends on what was the presenting problem in the first place and what is it that you have been working on within therapy. I recall I had a client in which termination took a month, literally 1 month. We had to work and build toward it. The client definitely was showing progress throughout. They had a clear way of working through and showing how they can cope. But again, this was particularly with a client that was dealing with abandonment. So I didn't want them to feel like I was just dropping the egg on them. So my termination process actually was part of the therapeutic process. Thus, it took 4 weeks in which we started talking about the termination process. The first 2 weeks is looking at how is it going to be for the client. The next to the last one is being able to have the client share with me exactly how they were going to handle it and what troubles did they see before them. And then the last session was to be able to allow them to express whether or not they're ready. And at that time with that particular client, by the time we got to that last session, they was like, "No, I'm ready now." And matter of fact, it wasn't even a full session. It was where we talked for about 10 minutes. The client then shook my hand, and the client then walked out the door. You have to be able to gauge your clients to know exactly how much you have to do toward the termination process. So when services are no longer needed, we should be still continuing to treat our clients when the problems are associated. Always leave the door open, even once you're terminating and ending therapy. Let them know that if they have to come back, they can. Okay? Now, the standard does not prohibit psychologists and clients from reevaluating those treatment needs and to be able to continue in a therapeutic relationship to address any type of additional mental health needs. So by always allowing them to know that they can return or can return back for services, that guarantees that just in case things didn't work out, that we are not just leaving them out there to sink or swim. But again, one of the things that's also important that I share with you is that, say you work in an inpatient facility And you might have a client that you were working with, they were discharged. They're not going to be able to see you unless you have a private practice as well as working in a facility. And then that's some type of conflict of interest as well, so you have to be careful with that. But they're not going to be able to readily see you. I had a client that was discharged, and for several months, not weeks, months, the client would call and he would attempt to have therapy via telephone, which I was told I wasn't allowed to do. I attempted to refer this client to outside for outpatient therapy, and they just refused. He was like, "No, I just want to work with you." It got so bad that the client actually returned back to the campus, and you know, demanded to see me for therapy. Now, that actually was kind of scary, to be quite honest, because the nature of this particular client was that they had anger issues, and they also had violent tendencies. So it was really scary in a sense, because now I had to watch my back outside of the hospital setting, because they became angry and upset that they no longer had me as their therapist. And you have to be careful, because there have been times when we as psychologists um, are placed in harm's way because we follow policies and procedures and being ethical. It's again a balance that we have to maintain. However, we have to make sure that we try our best to provide a clear understanding, but also understand that the client may not accept what you tell them, and may still want to take it into their own hands. So always be careful with that. I mean, we've had, I know at Mississippi State Hospital, we've had psychologists that actually was attacked in their own home by former patients. So it's real, and it's something that we have to always consider. But it's not supposed to stop us from doing our jobs appropriately. All right, so the client and the patient's really not likely to benefit. This is applying when course of therapy becomes reasonably clear that client's not responding to your treatment. I think I told you about one client I had where we kept going over the same thing over a course of a month, and it was like I asked the client, "Why are you here?" Sometimes it's going to be where you'll have a client. There's a saying: therapy is only effective when the client truly wants it. Okay? If you know that your client is not benefiting from anything that you're doing, then you really shouldn't be continuing on therapeutically. But you have to make sure that they're not gaining anything from it, and that therapy is actually becoming a hindrance instead of being helpful. A patient or client is not responding to treatment was one area. Newly uncovered aspect of the client's patient's disorder is not being amended. It can toward that treatment modality, and that might be because the new presenting problem might be outside of your area of competence. So if you're not able to work with that particular problem, then you shouldn't be trying to, and then that's when you have to look toward terminating and getting the client the appropriate care necessary. And if a client's just unwilling and unable to comply with treatment, then there's no purpose for them to be there. Again, though, you make every effort to discover and assess whether or not that's truly the case. There's times like I had a child, an adolescent, who for like 3 weeks we didn't talk at all, but that was part of the treatment process because he was quite oppositional. And in that sense, it was where developing rapport was quite difficult. And the second part was he was court ordered, so he had no choice. And you might have a court ordered client who don't want to do anything, but they still are forced to attend those sessions. Even in those particular cases, if it's where you see after a month or so, even though they've been court ordered, that nothing is happening, then guess what? You need to write a report for the court to understand that this is not working, they are non-compliant, and thus it has to end. All right, so the client patient is being harmed by continued service. Sometimes we hate to let go of clients. There are times when we become attached and we don't realize it. Inadvertently, it can happen. So we have to always be on guard to understand why we would continue services for a particular person or individual. There are instances that it's unexpected to react to specific treatment modalities, like with major depression or a psychotic episode or the exacerbation of impulsive or addictive behaviors that do not respond to those continued efforts of the psychologist. There's times when we think we're doing our best, but it doesn't really work. It's actually becoming more harmful than not. I can only return you back to working at Texas Youth Commission, and my reason for termination was that I felt that the services we were providing was actually hindering that youth, that we was creating the problem rather than fixing the problem. And because of that, and this is actually me wanting to terminate services because of it, was what got me terminated myself. So, like I said, sometimes you're going to have to make those tough choices, and whether or not you're going to stand up for your client, stand up for the field itself, and make sure that they have a clear understanding on why you're doing it. But when it's appropriate to terminate, the clients or patients should be referred to alternative treatments, which in this case I was trying to get them on our outpatient treatment. I wanted them out of that facility because that facility, their behaviors only became progressively worse. The behavioral patterns were inappropriate and was becoming more violent day by day. So that's something you have to also consider. All right. So psychologists may terminate therapy when they're threatened or otherwise endangered by a client or patient or another person with whom the client and patient has a relationship. This is something that you can't take too lightly. I would also recommend consulting when this is occurring, but if like a client tries to hit you or worse, then no, we don't expect you to stay within that therapeutic relationship. But even with that, I would want to say that it's important for you to still try to get alternative services set up for them. Have someone else approach them. Psychologists may also request a protective order against clients or patients who they suspect will threaten or harm them. Prohibitions against revealing confidential information do not apply when psychologists must call authorities or others to protect themselves from threats or harm. So this is one of the limitations, and this is one of those limitations that you probably are not going to clearly express at the very beginning, but you should make clear that in time of circumstances of if they become a harm to themselves or others. You may not necessarily say like me, but you're the other in that category. So at this point, you are allowed to be able to end therapy. And you may break confidentiality if you have to call the police, for example. All right, so except where precluded by actions of the client or patients or third-party payers prior to termination, psychologists will provide a pre-termination counseling as well as suggest alternative service provided as appropriate. And that's what I was talking about, like when I met with that client and we did the pre-termination process. Then we had like 2 sessions, 3 sessions of pre-termination prior to the last session. That's what this is covering for 10.10c. Now here, when we're talking about pre-termination counseling, again, you want to make sure that it's advance notice whenever possible. You don't want to just have a client come in and say, you know what, you're doing so well today that this is going to be the last session. That's a shock for the system, so no, you don't want to do that. Being able to discuss the client and patient reasons for the termination, you want to let them know what progress you see them doing, that you find that the presenting problem is no longer a problem, and be able to allow the client to be able to express and share whether or not they feel the same. Okay? Any type of questions that the client might have about termination, you want to be able to answer that. And again, you want to be able to provide referrals to any kind of alternate services. You also would want to do any kind of follow-ups. So this is ending our lecture, not only for this week, but this will be the last lecture that I give you for the semester. Okay? Please make sure that you review all the material. Make sure you have caught up on all your reading. Please make sure that all the assignments have been done and completed. You will be receiving practice quizzes to help you to review for the exam. And then the final exam will be scheduled to you for next Thursday. So from Monday through Wednesday, you'll have the window will be open for the private exam for you to do. Thursday, the final exam will open as well as close on Thursday. If you have any questions or if you need to meet with me, please feel free to set up an appointment. You can send me a message in the inbox. And otherwise, I thank y'all so much for your participation. Again, I'm sorry that we did not have the most optimal time for this semester where we would have been able to interact with one another, but I think the information that you receive will still help you in terms of directing you on how to deal with ethical dilemmas and issues. Do use all the resources that you find here in Canvas. Canvas will be open for you a little beyond the semester. I tend to like to keep it open in case you need to go back and find any additional resources. On that end, you shall hear from me again next week to just announce when the practice quizzes will open. And please do take care.